Good morning, and thanks everybody for coming. The number of people in the room would suggest this is an area of some interest, and we could spend the rest of the week talking about what happened during our trip. It was really it was a fascinating trip. I'm really grateful for the opportunity to be able to have done this. I we got the invitation. I've been working on that for about 2.5 years. Let me go, and I finally got the opportunity, and then I realized I was gonna need to let people know. So I went and talked to my boss, the dean, Dr. Reese, who is the dean of the School of Medicine, vice president for medical affairs. I said, Dr. Reese, I'm going to go to Afghanistan for 3 weeks. I just wanted to let you know, and I feel like I should appoint somebody to run the program and run the hospital while I'm away. Swallowed a couple of times, and he said, "You mean like where the war is? You're going where the war is?" I said, "Yeah, yes, sir. I'm going where the war is. Is that a good idea?" I think it's a good idea. And he swallowed a couple more times and said, "Okay, you know, you can go." The dean's been incredibly supportive of all of these ventures and me traveling around the world doing things like this. He's really strongly endorsed all of our work, and I'm really very, very grateful for his support and for being constantly supportive of our international efforts and the international research. He's really underwritten all of that, and for Sea Stars. The point of this was to do a trauma systems review. And it's probably funny you don't think of the trauma system in Afghanistan, but there's a trauma system in Afghanistan. It's designed to do very much what our trauma system is designed to do. It's designed to deliver kids to the right place, the right care, the right amount of time. And the motto and the organization, frankly, is very, very similar to Maryland. A year ago, 4 or 5 surgeons went and did a trauma systems review. It was Ron Mayer and Don Trunke and Warren Dorlack. And they made a number of recommendations, and they asked us to go over to take a look and see what had happened in a year and to give another sort of set of perspectives as to what, if anything, could we do to perhaps modify things or do things a little bit differently. I didn't really think about it much. It was actually the first time, maybe since 40-something years ago when I went to college, that I had no idea of what this was going to be. When we went to Haiti, I could think in my head and say it's going to look like this, and I was pretty close. We would have nothing, and we had nothing when we got to Haiti. We had a lot of heat. But I was completely in the dark as to what this was going to be. We landed in Bagram Air Force Base, and I knew this was not sort of going to be going to summer camp when this big 20-year-old Marine hopped on the airplane. We're grabbing all of our stuff, and he looks at me and he says, "Dr. Scalea." I had no idea how he knew who I was. "Dr. Scalea, welcome to Afghanistan, welcome to hell." And it was a fair characterization, I thought. The dust was everywhere. You can't walk or take a breath without sucking in a bunch of this unbelievably fine dust. It was 100 degrees, and everybody got sick. Apparently, it takes about 3 weeks. So we were getting well as we left. It's an incredibly austere environment, and in this there is a tremendously complicated trauma system. It is the DoD mandate is that from time of injury to time of arrival at whatever level of care has to be within an hour. or it gets investigated. And it's called the golden hour. The resuscitation is pushed very far forward. And on one of the helicopters that carries the blood and plasma is the container where they package the blood. And on the container it says the golden hour transfusion box. Sort of felt like I was home. You know, it was very, very similar. And the notion that it's a time-related disease is absolute here. Now, you know, it's the trauma levels of care are reversed. So a level 1 is the very far forward surgical team. Level 3 is the highest or the most sophisticated in Afghanistan. Level 4 is launched to a level 5 is the United States. And so we had the opportunity to visit level 2s, level 3s. We came through Launchstool where we had all been several times in the past. And so we really were able to get an appreciation of how people flow. And they flow very quickly, and they flow with a fair bit of sophistication. And there are many, many levels of pre-hospital care, which range from as simple as a helicopter up to these flying intensive care units, the MIRTs, that mostly run by the British, that are staffed by physicians and pre-hospital people and nurses. And it's essentially a flying intensive care unit. And all these get layered on top of then the critical care air transport, the CCAT teams that were developed by Warren Dorlack and Bill Beninati and several other people. Bill, many of you remember, was here a few years ago. So there's an awful lot of relationship here. We saw, the injuries are really as bad as you think they're going to be, because about 50% of the injuries now are IED injuries, and so they are designed not to kill as much as to maim. And so what is the everyday fare is bilateral lower extremity amputations, open pelvic fracture, some external GU injury, and then usually one upper extremity injury, because if you carry your gun like this, it's your non-dominant hand that's down, and so that's what is at risk when you step on whatever it is you just stepped on, because the war now is being fought on ground, not in vehicles. And so this is multiple amputations are the injury, the signature injury now of this war. And we've obviously cared for a few of those kids here. It's will continue. Despite all of the challenges, and despite all the trying to deliver this care over a huge terrain, the survival, if you're an American troop and you survive to get to the first level of care, whatever it is, the survival last month was 96-point-something%. So I don't think didn't think that. I don't think that that's going to get any better. That's about as good as that's ever going to be. There are going to be some challenges, and we had some thoughts on the processing of this. And so, how do you continue to provide that level of care as the American presence or the multinational presence starts to go away? That's going to be a complicated set of circumstances, and the discussions are already ongoing. I felt like I was home here, Jeff. They said, well, how do you deliver the same amount of care with fewer resources? Oh, I've heard that before. Every day I think I get to hear that. How do we not lose the lessons that we have learned in 10 years in Iraq and Afghanistan? Because it's nice to think that we're never going to war again, but that's probably optimistic. And 5 years from now, wherever, in whichever desert we happen to be, it sure would be nice to have all of that knowledge packaged. It is most of the people that are part of the medical corps in this war will not be there. They will be in different roles, or they will be out of the military. So to have to go back to the beginning and learn all over again doesn't make a lot of sense. And so we had a number of thoughts about how it is that you accrue data, continue to accrue data, learn lessons, and then package those lessons in a digestible form so that the next time you can open the box and take the trauma system out and deploy it rapidly, using all the lessons we've learned, and we've learned a ton of lessons. And the last part of this is, how do you ensure that the training mission stays at the front of the agenda? Because once again, what we don't want 5 years from now or 4 years from now or whenever it is, to have nobody trained, to have to go back to the beginning and start training people in injury care. And it's why I think that programs like Sea Stars are just so important. They're so much of who we are. We've been at this now 10, I think, right? 10 years, right? So we've been at this a long time, and it's a really important part, I think, of who it is we are. Training is one of the core missions of shock trauma. It's one of the core missions of the School of Medicine. It's one of the core missions of the School of Nursing. It's one of the core missions of the campus. And so we have to continue to underwrite that. We're clearly making some plans in the new building to be able to train. That's a lot of what it is that we have to be able to do. And I'm going to introduce you to Dr. Fang. Ray, why don't you come on up?
Thank you, Dr. Scalea. I'd like to begin by thanking Dr. Scalea for volunteering his time, his expertise to visiting our trauma system and theater and trying to add to our improvements in casualty care. And then I'd like to thank, again, Dr. Scalea, the Shock Trauma Center, and the University of Maryland Medical Center for their daily support of training our medics, our Air Force medics, to prepare for deployment over the past 10 years. I can say that the trauma leadership in the military, Dr. Scalea mentioned that we had a 96% survival, perhaps, in the month that he was there when we look at our statistics, the data that we've gathered. But I think that we still are looking for ways to improve. You know, you can look at the mortality numbers, and that is an easy figure to look at, but there are other things too, such as quality of life, amputation level, cognitive function, and those are all things that we can continue to try to improve upon based on resuscitation, treatment, evacuation, etc. So the reality is that many of us in the military gain our trauma care experience only through deployment. Our job when we're not at war and we're at home is to take care of beneficiaries, retirees, and for the most part, most military medical personnel don't care for a single trauma patient during their daily military practice. Yet, when a war happens or an event happens, we're expected to deploy and take care of some of the sickest patients that there are in a very austere setting. So it's not fair to the patients, it's not fair to us as medical personnel to put us in that situation without proper training. And some very wise, forward-thinking Air Force leadership 10 years ago, in partnership with Dr. Scalea and the Shock Trauma Center, created this collaboration here. So C-STARS, as often referred, stands for the Center for Sustainment of Trauma and Readiness Skills. And the Air Force, we have 3 such platforms, and our sister services, the Army and Navy, have similar platforms as well. We have partnered with busy civilian trauma centers to try to provide trauma and critical care exposure, experience, currency to our Air Force medics, and then also to allow deploying Air Force medics, Army medics, etc., to have an exposure before they go to the theater of war. We've had some of our students come through and say, well, you know, in a month of being deployed, I'll be up to speed. But again, I think it's really unfair for that first month that you have to have this learning curve. So our job here is to try to make you as prepared as possible from day one to do your job and to do it well, because our casualties deserve no less than that. So this has been a fantastic partnership. I think with the new tower There are many more opportunities for us to increase our collaboration partnership, and we've made suggestions to leadership about what we can do. But I think that this will be an enduring relationship, and we are very appreciative of it. This relationship started shortly after 9/11, and in the 10 years, we have about 11 courses per year. Each course averages about 30 students or more. So if you say very conservative estimate, let's say that we've had 3,000 Air Force students rotate through here. If you say that each Air Force student touches 10 to 100 casualties, and we'll just say 10, again, to be on the very conservative side, that's 30,000 patient contacts that hopefully have been improved by their experience here. And maybe if you say 100, 300,000 patient contacts have been improved by their exposure here. And Dr. Scalea had mentioned to me that when he was rotating, many of the people came up to him and said, you know, I remember being there. I remember you from my rotation 1, 2, 3 years ago. So again, we have great impact beyond what we do here because it's kind of magnified exponentially by the number of people that we touch.
What has happened, I think, is that one of the people said that you shouldn't confuse the Taliban being ignorant with being stupid. They can't read and write, but they sure can make bombs. And it has been a series of actions and reactions as the IEDs have changed. The resuscitation strategy has changed, as have the way we try to care for the troops. And so, the good news, if there is good news about IED injuries, is that you can control external hemorrhage from extremities with tourniquet. And so I believe that one of the reasons that the survival is so good is that we have altered the way we do things. Troops carry tourniquets. It was fascinating. One of the guys, or actually a number of the guys, have a patch on their shoulder with their blood type, so that you come in and you know what their blood type is if they can't speak. It's so that I think that the lessons for this war will be the lessons for this war. That may be different lessons for the next war, but learning how to set a system up and then deploying that system, organizing it, understanding what resources are necessary, and doing the training, I think, are the generic trauma lessons that need to be learned and memorialized, not just learned for now, but learned for 5 years or 10 years from now, that will be important. And I am 100% in agreement with Colonel Fang that it is vitally important to maintain the training so that people are up and ready to go at a moment's notice. And the only way that I see to do that is to continue to partner with high-volume civilian trauma centers. Do we see IED injuries? Not usually, but do we see some terrible combination pelvic and lower extremity injuries? Yeah, we do. And so it's not the same injury. I understand that, but a number of the principles for caring for those injuries are very similar. And so if you understand how to do it, then you understand how to do it there as well as understanding how to do it here. They're using, there are a couple of things, maybe, Dan. Their tranexamic acid is now being used in Afghanistan. As many of you are aware, there was a big randomized study done in Europe. It has not gotten a lot of press or a lot of traction in the U.S. Maybe it should. The guys in Bastion are doing have actually a fascinating way of taking care of the IED, the kids with external pelvic hemorrhage, which is because there's no angiographic embolization there. So what they are using is opening the abdomen and then doing bilateral hypogastric temporary occlusion. And as a bridge. Then they take them off the table, take them over to the scanner with the tourniquet still on the hypogastric arteries, do the scan to see where the rest of the injuries are, get the kids resuscitated while the hemorrhage is controlled, bring them back to the operating room to do the remainder of the first part of the surgery, and then put them in a, then they go up the various echelons of care. That's an interesting concept for people with bad crush injuries to the pelvis. And so I got that in the back of my head. We'll use that once or twice in the next year for the people that have exsanguinating hemorrhage. The military is still very much, it's a whole blood resuscitation, 1-to-1-to-1, and the military data, of course, is very convincing.